Got it. My name is Sean Wenger. I'm one of the vascular residents here at Mount Sinai. Happy to present a case of endovascular management of a celiac artery aneurysm that I performed with Dr. McKinsey. This is a 53-year-old gentleman who was referred to our office with a history of COPD, hyperlipidemia, diabetes, hypertension. He was found to have a celiac artery aneurysm just under 2 centimeters. He was a current smoker, about a half a pack per day for the last 30 years. This aneurysm was found during a workup approximately 1 year prior. He had some hematuria, transient hematuria. On a CT scan, it was discovered. The issue arose that he's a mass transit worker. He's a bus driver, and due to this revelation in his medical workup, he was actually placed on leave and unable to perform his duties, and it was actually creating quite a problem for him. Patient was asymptomatic on presentation with no abdominal or back pain. On physical exam, he was obese, he was overweight, no other significant findings, no abdominal bruits, palpable femorals and distal pulses, both in the upper and lower extremity. Labs were within normal limits. On arterial duplex, we saw an approximately 1.7 centimeters celiac artery aneurysm with minimal thrombus, and on CTA, we saw a 1.8 centimeter celiac artery aneurysm. So we'll show the initial scan. Unfortunately, I don't have the entire scan. I have just clips and 3D reconstruction. But as you can see here, we have the celiac artery coming off the aorta, and there's a relatively normal diameter segment of the initial celiac access that leads to the aneurysm, and then pretty even bifurcation to the splenic and hepatic. I believe you can see the left gastric coming off there as well. Here you can see the 3D reconstruction delineating the same anatomy. A little close-up here, you can see again, a normal segment of artery here, a relatively normal segment of artery here, and then, flush bifurcation off the aneurysm distally. So I guess we can pause here and let, anyone in the audience want to suggest what they would do in this situation, or what they have done in the past for a similar patient.
What would you do? I mean, this guy, the first time I said is, don't get pregnant.
Yeah, pretty old, don't get pregnant.
But I can't work anymore. I mean, that's New York at its finest. They actually said you can no longer work as a bus driver as long as you have this aneurysm.
In general, I mean, a 1.8 centimeter sort of mesenteric aneurysm carries a very low risk for this patient and needs to be followed. I would say do nothing. I have the situation recently with a patient with an aneurysm, the same thing, relatively small aneurysm. They wouldn't let the guy work at all. And then you have to sort of work through those things. The thing is, it's not a location that carries a very, it's not a simple reconstruction or a simple procedure to do anything to be able to correct this aneurysm that carries very low risk to this patient.
No calcification.
No.
So let's say, I was pretty much, okay, you want to go back to work, what can we do? What would you do for him?
We have one question or comment from.
Sorry, Dr. Raven.
Is that I can't really follow that branch up. I see a splenic, I see a hepatic. Is that a left gastric?
Yes. This is the left.
Take off the left gastric. Because on the reconstructions, it looked directly superior, where usually.
Could you just?
Or was that a little pseudo pocket off of that?
I apologize for not having the full CT scan. It's from one of our other campuses, but that may be the case. It looks here on the reconstruction as though it's coming off in this projection, so that may be the case. But there was no other aberrant branches.
And how about just embolizing, lightning celiacs all the time?
Or embolized two of the branches and landed a covered stem in the hepatic.
Yeah.
Definitely an option.
The most interesting point to discuss is also if we want to treat this patient, I wouldn't do that. But if we want to do it, which is the most important branch to preserve, the hepatic or the spleen artery? So we had a lot of discussion in our team. What do you think?
You can take the splenic proximal pretty much with your trying to say, I'm gonna say only one and just do a fairly straightforward case, I would embolize the celiac, or the splenic, and then just put a long covered stent, from the origin into the hepatic itself.
Would you mess with the left gastric?
Beg your pardon?
Would you mess with the left gastric?
It was too small.
Yeah, it's pretty small.
So you would use a cover stent probably
You'd have
in
to.
this, yes.
I mean, I guess in Europe you may have the multi-level layered graft, which I'm still not convinced is a good idea. But if you really want to treat the aneurysm, then you'd have to, I mean, the only other option would be to put a bare metal stent and then go through the interstitium and try and coil it. But you don't have a neck, so I think
Yeah.
that's really a bad idea. So you can coil it, you can do a covered stent, you can operate on it, which all of the residents were encouraging us to do.
I was there. I was a big advocate for that.
Just get a little incision around it, really fine, you know, it'll be great, it'll be great.
Yeah, in a couple
operation.
days.
So, we didn't do any of that though.
Yeah.
So I'll, oh, sorry.
Flip the cards over.
Yeah, let's lay our cards out. So we performed bilateral ultrasound-guided common femoral access. We put in 9 French renal double curve guiding sheets and performed our aortogram. Again, I apologize for the limited images. But you can see here, essentially, getting our sheets up, and you can see the projection of the aneurysm, and we get our wires out into both the celiac and the hepatic, and exchange our sheets up into each of those vessels, and passed up 2 6x59 ICAS stents. One from the celiac origin to the hepatic, as mentioned, and one into the splenic, with some extension into the aorta. Was able to deploy them successfully simultaneously. Flared them proximally with an 8mm balloon, and had successful perfusion of both the splenic and the hepatic arteries at the conclusion. On follow-up CT, you can see the 3D reconstruction here of the double D, configured stents proximally and their extension into the hepatic and splenic, respectively. A little closer up view of it. On
Kissing 8mm balloon?
yeah, just flared it proximally.
But they were in that celiac.
Yeah.
The only thing you flared is the aorta.
Yeah.
So it wasn't much, yeah, 'cause that's.
No.
I didn't try to go up to a 16 in the celiac.
No. No.
We just tried to
Touch.
the proximal aspect to flare into the aorta, so if you had to recanalize, you could, and try to make sure you had a good double D seal right there.
And on this CT scan, there was no evidence of endo leak. And on the follow-up visit at a month, duplex in our office showed patent celiac to proper hepatic stent and patent celiac to splenic artery stent with no flow in the aneurysm sac. The patient did well and was able to go back to his occupation.
How often are you going to follow this patient, since there's always significant concern of compression of the orifice of the celiac, and in this time, you've chosen to put 2 stents, not just one, into the orifice of the celiac. Why do you think is sort of this chance?
Natural
of
course,
staying
yeah.
open? How closely are you going to follow?
So I think initially our plans are, initially 1 month follow-up, kind of similar protocol to how we follow a lot of our patients who have stents when we do our fenestrated grafts, 1 month, 3 months, 6 months, and yearly after that. Hopefully once we get to that point, we don't have any issues. It's hard, to predict. I think there's definitely a risk, and that's something that we discussed with them preoperatively. But it's something that we took, a known risk that we took. So.
I think, that was certainly part of our concern. You never really saw a compression of the celiac axis.
Yeah.
And we've all seen it where you see the median arcuate ligament come down and you get aneurysm beyond that.
Mhm.
That was one I think you would obviously fail if you put a covered stent there. This one, it was something that, is it overkill? By far, this is overkill. No doubt about it. I'll be the first to admit that. If it wasn't for him wanting to go back to work and couldn't go to work, I definitely would have just followed. But it was pretty much much, and he was also one wanting to save every potential vessel he could. Really, I felt like if we had any problems, you always can come in and overdilate further and crush the, the splenic stent if you needed to get a good seal. Fortunately, we've had good seal. We're following on a 6-month basis with ultrasound.
That you're more worried about Sill than Pace.
Oh,
Yeah, he's gonna probably, he could include asymptomatic, why would you even?
Yeah, we see a lot of included celiac, so
Yeah.
that wouldn't too much issues.
Yes.
All right.
It was a great case. Thank you very much. Congratulations.